Good evening. Matinee വെബിനാറിലേക്ക് ഒരിക്കൽ കൂടി എല്ലാവർക്കും സ്വാഗതം. ഇന്ന് വളരെ പ്രത്യേകതയുള്ള ഒരു വിഷയമാണ് ഹെൽത്ത് മിഷൻ, ഡിജിറ്റൽ ഹെൽത്ത് മിഷൻ. അത് ഇന്ത്യയെ സംബന്ധിച്ചിടത്തോളം എത്രമാത്രം പ്രയോജനകരമാണ്, എന്താണ് അതിൻ്റെ ഇംപ്രൂവ്മെന്റ്സ്, ഇങ്ങനെയുള്ള ഏരിയകളെ കുറിച്ച് നമ്മോട് സംസാരിക്കുന്നത് വൈസ് അഡ്മിറൽ കണ്ണൻ സാറാണ്. സാർ ഇതിനു മുമ്പും പല ക്ലാസ്സുകൾ വളരെ കൃത്യതയോടെ ഇന്ത്യയുടെ ഭാഗമായി അല്ലെങ്കിൽ ഇന്ത്യയിലേക്ക് എത്തേണ്ട പല ഇന്നവേറ്റീവ് കാര്യങ്ങളും നമ്മോട് ചർച്ച ചെയ്തിട്ടുണ്ട്. അപ്പോൾ തീർച്ചയായിട്ടും ഈ വിഷയവും പ്രത്യേകിച്ച് നമുക്കറിയാം ഹെൽത്ത് മിഷൻ എന്ന് പറയുമ്പോൾ തന്നെ വളരെയധികം വ്യാപ്തിയുള്ള ഒരു തലമാണ്. അപ്പം അതിനെക്കുറിച്ച് ഇന്ന് നമ്മളോട് കണ്ണൻ സാർ സംസാരിക്കുമ്പോൾ നമുക്ക് ആകാംക്ഷയോടെ ചേർന്നിരിക്കാം. നമ്മുടെ എല്ലാവരുടെയും പേരിൽ കണ്ണൻ സാറിനെ വേദി ക്ഷണിക്കുകയാണ്. കണ്ണൻ സാർ, യു ആർ വെൽക്കം.
Thank you, Dr. Sabu. Good evening to everyone. And first of all, I'd like to thank Dr. Sabu for giving me an opportunity to speak on a topic which is going to have a lot of relevance to most of us in India very soon. So let me start by saying health is wealth. It's an age-old adage which applies to individuals, it applies to societies, it applies to even a country. Just like you and me feel committed that we have to allocate resources, allocate finances for the healthcare of our family members, the government is required to allocate resources in the form of manpower, in the form of facilities like hospitals, nursing homes, availability of medicines, etc., for its citizens. It is the government's duty to do that. And the healthcare scheme which government would set up should be inclusive to all sections of the society, should be uniform, should be comprehensive, and at the same time affordable. This is what every citizen wants, and that's what the country wants. Our population is 136 crores, and if you have to set up a healthcare system which meets all these requirements which I just mentioned about, you require a humongous source of resources, which presently we don't have. And there are some serious challenges in generating these resources. Many other countries also have faced similar problems, and they have taken up the issue. Of course, they didn't have so much of population, but they have faced the roadblocks which were there for the healthcare systems by bringing in technology, by bringing in digital technology. So India has also launched a digital mission in 2020. I don't know how many of you are familiar with it or heard about it. We're going to discuss that today. And this initiative which has been taken by the government is something very aspiring for them to realize. I think they are looking at a huge target to be achieved. I think it's a very ambitious target. I've asked a question in my title of the talk. Is it too ambitious for us to achieve this in India? Let us discuss this. To make it easy in understanding and also enable anyone who wants to view it later, I have structured the presentation in 4 parts. Essentially, you can do installment viewing so that for 10 minutes, 15 minutes, you can see one part. The first part is, what is digital health? There are many definitions of digital health, but I will share with you what the international opinion is and what we feel in India is. The second part is, what is India's present health scenario? What are the various parameters which define India's health scenario today? The third part is, what is India's proven prowess to develop a dedicated digital platform for healthcare. We don't have it now in full measure, but do we have the capability to do this? We'll discuss that very briefly. And the last part is on the digital mission itself, how it has started, where it has reached, what is left to be achieved. And then you can decide, is it too ambitious or no? So with this, I upload my presentation. Sabu, I'll just share my presentation.
Okay, sir.
Can you see the presentation now?
Yes, sir. Yes, sir.
Okay, fine. Right. So, is India's digital health mission too ambitious? This is the topic. So let us first go to a very brief introduction. I told you about India's population, 132.6 crores, requiring huge resources. We are a 3.5 trillion economy, almost 3.5, not reached there. But we are able to allocate only 2.1% of our GDP for healthcare, which today is meeting only 42% of the expenses. The remaining 58 is coming from somewhere else. So let us see that. Citizens are paying out of their pockets 47% for their own healthcare. You go to a private hospital, you get a huge bill, you pay it. That is a part of this 47%. And the remaining 11% is coming from some donations, some insurance, etc. Now, can the government identify a suitable technology by which per capita cost is brought down, at the same time coverage is more? So you enhance the coverage and also bring down the cost, then you will be able to make it more affordable for the citizens. And can India do it ourselves, or you need to look at some other country for this? This is the topic which you're going to discuss. I'm going to the first part, that is, what is digital health? Digital health is the intersection of healthcare and digital technology, what I've shown in the diagram. So the DH, I'll be referring to as DH here and after, should be as large as possible. So that is the aim, to make sure that you're able to bring more healthcare aspects into digital technology field. It can be in diagnostics, it can be in monitoring, it can be in telemedicine, it can be in treatment management, etc. So let us look at, I told you the intersection, and it should have the speed, scalability, accessibility, inclusiveness, and uniformity of digital systems. Digital systems have inherently these qualities. So you take these qualities of the digital system, these are positive aspects, and bring it into DH. And at the same time, make sure the data is protected. The individual's health data is protected and secure. But the macro trends which are happening can be given to policymakers to decide whether a different program needs to be launched or a different policy needs to be made. Very recently, if you've seen yesterday's paper, they said Lancet has come out with a publication saying in India, diabetes is prevalent by so much percentage. It's a macro data, and the government can look at it and see how they can reduce the prevalence of diabetes amongst the population. I'm just explaining to you that. And this area of intersection, as I showed you, should be as maximum as possible to get the best benefit. So let us look at what all aspects in healthcare have been digitized so far in the world. First, they went for creation and sharing of medical records in digital domain. That's the time when digital computers started coming in late 80s, then 90s. They started storing all these medical records in digital domain, patient-wise, which can be consulted by doctors, which can be referred by patients to some other doctor, etc. Then X-rays became digital. Then ultrasound became digital. Then MRI became digital. So all these diagnostic tools became digital. Then telemedicine came so that you can speak to the doctor through your electronic communication, and you're able to get advice from him. He's able to see your digital X-ray. He is able to suggest you treatment. A prescription will come by that digital domain. Then they started having equipment for remote monitoring of patients who are lying in the house, whose vital statistics, whose parameters are monitored through suitable digital equipment, and through a modem, it goes to the hospital. So the patient doesn't have to come to the hospital. Maybe he's a very old person who can't stand the strain of being hospitalized. So he remains at home, and the doctors from the hospitals are able to monitor. Then robotic surgeries came. They are also digitally controlled, and that is very quite prevalent in many hospitals in India. Then came wearables and ingestibles. That means you wear something on your wrist, wear something on your neck, and monitors various aspects of your parameters, maybe blood pressure, heart rate, pulse rate, etc. And you're able to refer it back to your doctor wherever he's sitting. Or you're able to have a medicine, a tablet-like thing which has got RF connectivity with the outside system as an ingestible, and that goes inside your body to make many measurements of what is your internal parameters. Similarly, virtual care has come. There are artificial intelligence which has come in, which is able to do virtual care, data analytics. And there is a software which has got developed recently as a medical device. I'll just give an example. There is a patient who has a problem of snoring, and he gets short of breath while he's asleep. So there is a software which has been made to the medical equipment which monitors his breathing rate, and when he's having sudden difficulty in taking the breath, then a small mechanical gadgets which is fitted to his hand will slightly wake him up, shake him up, and he changes his body portion from left to right, and he stops snoring and is able to breathe back properly. This is totally done by the software and the equipment. This is something which they have recently started doing. Similarly, they are doing for heartbeat also, which can parallelly alarm the nurse on duty or the doctor on duty. So with all these developments in digital domain, in your healthcare equipment and healthcare process, can you administer digitally healthcare? Can it become a part of e-government? Like many other things have become a part of e-government. So let's look at that. The digital absorption or the digital adoption by a country depends upon three factors. One, there should be good infrastructure. Two, the population, the citizenry should be knowledgeable enough to use the digital domain, that they have basic education, they are not afraid of computers or digital equipment, which are many times unmanned. And the third part is they should be able to utilize the services available. This adoption index was done over many countries. Denmark is number 1. Finland is the number 2. Of course, their populations are very small. India is 105 out of 193 countries in the world. This survey has been done by UN. And our score on electronic e-governance is pretty low at 0.59. Very low for infrastructure, because our infrastructure does not cater for the entire length and breadth of the country. Our human capital is also not so savvy with digital gadgets. That is at 0.5. But our utilization is very high. Whatever is made available, we are using. So, are we ready to utilize healthcare through a digital platform? What has been the various e-governance modules which have been given, and where does healthcare figure in that? Let's have a look at it. These are various modules which are in the e-government, and I will quickly go and tell you how it has been utilized. The highest utilization of e-government service is on caste certificate in our country. 64% is the utilization people use for caste certificate. Then they use it for income certificate, followed by domicile certificate. And healthcare is not in top 10 today. So healthcare needs to come into the digital domain and make it attractive for citizens to engage in healthcare aspects through digital domain. That is the aim which we are looking at. So if you look at today's healthcare responsibility, healthcare responsibility is with the state governments, with the central government's funding for medical education, part of it, capital projects for new hospitals, AIMS, etc. So central, and also for many other schemes which the central government extends. So if you look at this graph which I've shown you, 42% is spent by government today on healthcare. Only 42%. The remaining 47% is by citizens themselves. They're spending money out of their pockets. And the remaining is around 10-11%, which is coming from insurance and various donations and some sponsorship, etc. So our allocation in GDP, which comes to 5.88 lakh crores, is not enough. We require almost double of that. And we don't have that much of money in the country to make sure that we pay for everything from the government. That is why citizens have to pay out of their pocket. And per capita expenditure from the government side is only 4,300 rupees per citizen in a year. So this is pretty low. And this, compared with many other countries in the world, this is very, very low. 4,300 is just coming to around $56 at the present rate, while in other countries, etc., it is, in US, it is something like $11,000 per capita. Or in Denmark and Finland, which we saw there, number 1 and number 2, it's around $7,000 and $5,000 per capita. So we are pretty low. Our availability of finance are low. Of course, our cost is also low. Costs in those countries are also high. So it may not be appropriate to make a comparison 1:1 with what it is, but definitely we are much lower than many of the Western countries. So there is a need for us to allocate more resources, and the amount of resources can be better managed for reach, for coverage, as well as for cost through digital technology. So that is what digital health is looking at. Managing technology, managing healthcare so that it is available to all the citizens at affordable rates. So let's look at what is the healthcare landscape in India today. There are 5 A's the National Health Policy of 2017 has identified. This health policy is still in vogue. I think last month, there was a new health policy 2023 released by the government. The cabinet has approved it and it has been released. But that does not talk about the healthcare or the various aspects of the health of the population. It only talks about manufacture of medical devices in India, and they are going for productivity linked incentive for them. So let us not look at 2023 health policy. Let's look at 2017 health policy, which has been made by the country in line with sustainability development goals of UN. So the present policy has 5 important aspects. First, increase awareness, health awareness of citizens. Whatever means you want, so that they are imbibing correct practices, healthy habits, etc. That's the first thing, awareness. The second is provide access to all citizens. And third is overcome absence of healthcare manpower. In many hospitals, especially in rural areas, primary health centers, you find healthcare manpower is not adequate, and very often a high percentage is absent. So this has to be overcome by making a career for a healthcare person in a rural area more attractive. Render affordability of treatment. That is a 4th A. And last one, ensure accountability of health institutions for providing healthcare, comprehensive manner, in a reasonable cost, and also making it accessible to all sections of the society. So just remember awareness, access, absence, affordability, accountability. These are the 5 A's of our national policy. And when you look at the key parameters of health of a country, it is population rate, fertility rate per woman, death rate, maybe per 1,000 people, what's the death rate, birth rate similarly, infant mortality rate, maternal mortality rate, and life expectancy. These are the 7 most important parameters for considering how our present population of India is. So I'm going to make a comparison between these parameters of 2010 and 2020. You can have a look at it. Population rate has come down. Fertility rate has come down. Death rate has come down. Birth rate has come down. Infant mortality rate has come down. Maternal mortality, everything has come down, and life expectancy has increased. This is the average life expectancy between male and female. Female is more than 70. Male is slightly less than 69. That's why the average is 69.7. So there has been improvement between the last 10 years on the various key parameters, but they're not good enough, because we've not been able to give healthcare to the entire population, because they're still paying out of their pocket. So let's look at the constraints which are there. One is budget, which I've told you earlier. Even though finance minister has said in the last budget it will go to 2.5% of GDP in 24-25, but at the moment it's only 2.1. Doctor to population ratio in India is 1:1600. WHO recommends 1:1000. This 1:1600 is pan-India. So if you look at urban areas, if you look at cities, it is 1:700. But in rural areas, it is 1:1900 or 1800. Situation is worse. Similarly for nurses, it is much higher than what WHO has recommended. So there's a constraint, and there's on manpower availability. Second, there are 30,000 hospitals in India, approximately, in public sector. But private hospitals are 44,000. And you look at the number of beds, it is 7.3 lakhs in public, 11.8 lakhs in private. So what happens if you have more private hospitals? Obviously, there are more beds also in the private hospitals. Out-of-pocket expenditure of the citizens increase. because there are not enough beds in public hospital. There are not enough public hospitals. So people are forced to go to private hospitals where there will be expenditure more than what you would incur in a public hospital. Apart from that, the distribution of the hospitals is not uniform between urban and rural. I told you about manpower first. It is comfortable ratio in urban areas, but rural areas, it is much higher than what WHO is recommending. So the distribution is also skewed. And because of this problem, the low-income groups are the worst affected. They cannot go to a private hospital because it'll be too expensive. When they go to a public hospital, it is too crowded. They have to manage with whatever is available. So the government started a new program in 2018 for their healthcare. And that is called, most of you know that, is Ayushman Bharat. Now, very briefly on what it is, the Ayushman Bharat gives 5 lakhs per family per year. Through any hospital, it's cashless. It'll be directly paid to the hospital. The government has identified about 10 crores families through socio-economic status, caste status. So far, 23 crores beneficiaries, including family members, have registered on this, and they're taken benefit. Around 51,000 crores have been spent on this, with about nearly 4.34 lakh hospital admission. The scheme is in progress in 25 states and 8 union territories, but there are 3 states who are not joined the scheme. That is West Bengal, Orissa, and Delhi, because they must be having their own schemes, which are as good as this, or perhaps even better. So therefore, they are not joined Ayushman Bharat. Ayushman Bharat scheme is voluntary as far as state is concerned. Many states have joined this through a trust created in the state government, or through linked with some insurance company, and then they have made a part of it. But the fact is, out of 28 states, 25 have joined, and all union territories, of course, have joined. In August 20, the government decided to go to a digital platform for Ayushman Bharat. So India took the first step to have a digital platform for healthcare in August 20. And we are almost there 3 years later now. And the program has kickstarted, and it all depends on whether we have been able to develop a good digital platform or not. So let us look at, have you been able to do it indigenously in India? Have you been successful in the prototype trials in some places, etc.? We'll have a look at it. So the government wanted to do this digital platform at national level, and they have been successful in Aadhaar, which has been issued for nearly 136 crores. COVID, they tracked the patients, the citizens, and the vaccine program. About 220 crore vaccinations were done through COVID platform. So that gave them confidence. Then they made UPI, which is for real-time payment, which is accepted even in few countries abroad today, Oman, Singapore, Saudi, France, etc. So that gave them more confidence that they will be able to have a digital platform. Then they brought ONDC. Many of you may be knowing it. ONDC is open network for digital commerce. They are competing with Swiggy and Zomato now, so that they are able to get many citizens given the food service at a much lower rate than Swiggy and Zomato. The government brought Gati Shakti for project management of infrastructure recently. And Aadhaar 2.0 is being built with blockchain technology, with new features. It's already started. It's a voluntary one. If you've got Aadhaar now, you can go to Aadhaar 2.0, which will have more features of your biometrics as well as of your data. So the government is very confident that they'll be able to make a digital platform for healthcare, even though digitizing healthcare is not all that easy. And we will see why it is so. Many hospitals have done it, I've written a few hospitals which have already successfully done it. There's AIIMS Delhi, Fortis, Apollo Hospital, Manipal Hospital, etc. They have done it. And most of them are in private domain, except AIIMS in Delhi. They have made digital systems for workflow. What does it mean? You go to a doctor, you already registered at the OPD, it is through the computer, you got a token, you go to the doctor will say, okay, go for an X-ray. He refers you to X-ray, and the reference goes through the computer, and you will just go to the X-ray room for your X-ray. When the X-ray is over, the digital X-ray will come back to the doctor, and he'll be able to see it on the screen. So you don't have to wait for the X-ray to be washed, filmed, etc. And this has enabled many things to be. Early detection has been realized, faster diagnosis. Some hospitals also gone for telemedicine. So all these things the hospitals are doing, but they're all islands. If you go to one hospital, you're hooked onto that digital network. Suppose today you go to Apollo in Delhi, and tomorrow you are in Bombay, or you are in Mangalore, and you want to go to Manipal Hospital. All the data which is there in Apollo Delhi cannot reach Manipal Mangalore. There's no interoperability. So you can say, this was done. You may have few details, and the hospitals don't give you the full data. They keep the data with themselves, hoping that there'll be a good reference when you go back again. But you're not gone to the same hospital again. You've gone to some other hospital. So the data is not available to you. And most of these facilities are urban-based. So rural people have got no benefit of this digital systems created in some of the high-class private hospitals. So it remains largely as islands of excellence, which have independent and they're not interoperable. This poor data portability and interoperability has led to fragmentation of digital coverage by hospitals. Every hospital has got some digital system, but it's a standalone. It is not accessible from outside the hospital. You cannot refer another doctor to it for him to have a look at your X-ray, or look at your ultrasound. It's not possible. So there is a need to make this data portable, interoperable, and that's a challenge for the doctors. For the people who are developing the digital systems. So there's a need to standardize various digital protocols which can exchange data, which can be accessible in rural India, urban India, etc. So what a government has done is, first they made a new authority called National Health Authority in 2019 and told them, you please develop this digital platform with the best help from the designers in India. And a year later, the government started the mission called Ayushman Bharat Digital Mission. In short form, it's called ABDM, and I'll be referring to as ABDM in subsequent slides. So this was launched, but this was launched after some initial work, but the entire digital platform was not fully set up. So how that platform has been made is any citizen who wants to volunteer to be a part of ABDM, he applies for a card called ABA. It's called Ayushman Bharat Health Account Card. You get a card which has got a code, a 14-digit code. Your Aadhaar card, for your benefit of understanding, is 12 digits. This is a 14-digit code which is given to you on this card. With this card, you are a member of the ABDM. Now, we are going to the last part of our talk, ABDM. Before I open the first slide, I want to tell you, in 2015, UN had issued a composite document called SDG, Sustainable Development Goal, out of which healthcare was one part. Based on it, India issued the National Health Policy in 2017. Then they created the National Health Stack, which is the digital system, for 2018, and then they launched ABDM in 2020. So if you look at digital healthcare, which we are trying to enter in India, which you're trying to bring in our rural and urban areas, it is something similar to what has been done in many other countries. Let's look at the experience of many other countries. More than 15 countries already set up this. Small countries like Estonia, bigger ones, Canada, Israel, Spain, Denmark, and to some extent in USA, UK, Australia, Korea, Japan. But if you look at UK, Australia, Korea, Japan, they just completed last year. And they took 6 years to do it because they had many challenges when they were trying to get all their hospitals integrated through this digital platform. So our hospitals, number of hospitals, and the number of citizens is much higher than any of these countries, or all of these countries put together. Our challenges will be much more. So one of the things which have happened simultaneously in the world, every medical equipment which is being manufactured today will give the data only in a particular standard. There are some engineers in the audience, they will understand there's something called an IEEE standard, and that standard has to be followed so that your digital medical equipment is plug and play. Easily the data will come to the server from where it can go wherever it's supposed to go. And it'll also support wireless communication over Wi-Fi or Bluetooth. So medical equipment, our data portability is there and their interoperability is there if they are conforming to IEEE standards. But this standard has come only recently, about 3 years back. So equipment which have been made earlier may not conform to this, but all equipment here and after coming will have this, which will strengthen your digital platform. And as I told you, software is also being developed as medical devices. I give an example of a person who had this problem of snoring, and they have been developed which are compatible to this digital platform, and it enables better attendance by the duty staff. So India's digital health mission, ABDM, which started in 2020, when will it finish? We've got a lot of area to cover. So let us look at what are the challenges in that. So the National Health Authority says objectives are very clear. Everybody knows objectives are inclusiveness, accessibility, efficiency, affordability, and the data should be safe. So there are no doubts about the objectives of ABDM, which is what is required. Then what does the ABDM consist of? There are some building blocks in ABDM. So let us look at it. The first building block. Now here I would like to tell you that it will be slightly technical. So I'll go slowly so that you can absorb it. There'll be a registry of citizens. That means all citizens who are taken ABHA card will be one data pool, one register of all the citizens who have joined ABDM. The second one is another register, or as they call registry, of all doctors, nurses, paramedics, dentists, midwives, and physiotherapists, etc., etc. All people who are dealing with healthcare, they're the second registry, along with their specialization. Obviously, every doctor has to join this. Either he joins voluntarily or he's asked to join. That we'll discuss a little later. But all the doctors in India put together will be in the second registry. And the third one is a registry of all the hospitals, clinics, blood banks, pharmacies, labs, scanning centers, along with their location. So there are three core blocks in ABDM: citizen, healthcare professionals, healthcare facilities. Apart from that, there'll be something for all the drugs which are cleared in India for sales, along with all the details of medical shops. The fifth one is the personal health record of a patient. Now here I would like to emphasize the health record of a patient. Suppose you went for an ECG to Trivandrum Medical College Hospital, which is the part of serial number 3. And when you are an ABA holder, card holder, and your ECG is taken, and that ECG remains in the same hospital, it is where it was taken. It remains there. It doesn't leave that digital portal, but a link to that file is available with the patient. So patient can look at it whenever he wants. He may not be able to understand. He can show it to another doctor through the link. He can go to another doctor, and that doctor through his hospitals can access and see this. So the personal health record of an individual is with the hospital where it was generated. It may be an ultrasound, it may be a lab result, it may be an ECG, it may be an MRI, whatever it is. And the patient has to authorize somebody else to view it. It could be another doctor, it could be another hospital, it could be his friend, it could be his relative, but he has to give the link to them so that they can view it. That is how the data is protected. It is just like you get your ECG in a piece of paper, you take it home, and you want to show it to somebody else, you show. If you don't want to show it, keep it in the cupboard. So the individual is responsible for making sure that only his approval is required to show it to somebody else. Now, I will show you how the data flows today. The patient goes to a hospital, the doctor sees it, he is able to visit the hospital, the doctor sees it, and all this medical data which I talked about are kept in respective hospitals. A part of it is given to the insurance company if it is required. But otherwise, this flow, which is from patient to the medical data, is an island in that particular hospital. It cannot be shared because of the various problems I told you. So you have, the consent of the patient is taken through another software called Consent Manager. And when all these are developed, you will realize the present silo model means it is an island, it's vertical, only within that hospital, will get shared to an open model through what is called UHI, Unified Health Interface. You remember UPI, through which you are paying GPay, PhonePe, so many things which you are doing. Similar to UPI, UHI is going to be developed through which various interactions will take place. We'll have a look at it. So there's a UHI in the center. There are hospitals, nursing homes, doctors, and the citizens all around it, all linked through UHI. So the technology principle, this is a slide, slightly technical, so kindly bear with me. All the development is done through open source development. That means software is taken from open source. It is not some patented software which is available only with a company. It's available in the internet. That is being used for developing this digital platform. To that extent, it is easy to maintain. Second, all the core blocks will be centrally maintained by the government of India. That means government of India will have the list of citizens who have joined, will have the list of hospitals, and the list of doctors and nurses, etc. Rest everything are done by state governments or by the hospital themselves. There will be provisions for security audit and privacy, which will be done as a part of the program. Data will be validated every time. That means it is the genuine ABA card holder and not somebody else trying to take out the data. And all blocks, which includes core blocks, plus the balance blocks of talk about consent and other personal health record, etc., all will operate through UHI. Now I'm going to show you how when UHI comes, the flow will change. So let me go to the next slide. So the UHI, the red block has come now. The patient will access UHI and he can take an appointment with the doctor, which is the green block. He can take an appointment with the hospital, which is the brown block, or he can go to the lab. He wants to take an appointment for scanning. Just taken through that. And the data output from the doctor or from the hospital or scanning center, all these are available only in their server. The concerned doctor can have a longitudinal data is how the patient's condition has changed over many months, etc. If he wants to do it, he'll be able to do it from, provided the patient shares that link with him. And otherwise, the data remains in the scanning center or the hospital or the laboratory, whatever be the place. Only the macro data goes to the government. That means how many people had diabetic issues, how many people had heart problems, how many people had this type of chikungunya fever, all those macro data without details of who got it, did it have a geospatial concentration, is it only in that particular village where you had this, those sort of macro data will be available with the government. Of course, anything to be shared with a third person will have to be consented by the patient. Now, the ABDM has progressed this project in these 3 steps. And I thought this is a very fascinating caption I want to share with you. They're thought big, they're thinking big, and they started small so that they can scale fast to wider coverage. So let's see how they have done it. The implementation strategy has been, of course, issuing ABBA card. They got the registry of professionals, hospitals, etc., populated with the efforts of state governments and union territory. While they were working on it, they realized there's an important factor for comfort of patients. They come in the hospital in the morning at 6:30, 7, thinking they will be able to see the doctor first in the OPD. They come early, wait for their number to be called. They go to the OPD counter, give their details, show the ABBA card, that person enters it or reads that card, and then he refers to the doctor. They wait till such time the number is called. So what they have now done is, when the patient takes an appointment, he gets a QR code in his mobile. With that mobile, when he goes to the hospital, let's say his appointment is for 11 o'clock, he goes at 10:30 or 10:45 only, doesn't have to go early, and just shows the QR code. The computer reads it saying patient has come. And of course, you'll be called in at that time. So this has enabled quick service to the patient. Their waiting time has been significantly reduced. This has been tried out in some union territories, and they found the results to be very, very good. And the citizenry is very happy with this new scan and share program which has been made. Now they're also thinking of, they're continuing thinking big. They're going to make organ donation also possible through UHI after some time, and it's fully tested. UHI has got enough budget, 144 crores has been given to be developed this, and let's see how they have done it so far. So what they have done is, they first did all the union territories, 6 union territories, not all, 8 union territories, but they have taken 6 union territories, and they did the phase 1 in union territories, which they completed. They got good results. When it came to phase 2, they had faced problems on developing issues like consent manager, when the patient gives a consent, how the data will get transferred to another doctor, another hospital, etc. So they are working on it. There's a technical paper which was made in December 22 by National Health Authority, and they still not resolved the issue. There are some glitches which they have to do in phase 2. But meanwhile, they are going to phase 3 saying ABDM can go to all states. So as of now, all states ABDM facility is open, even though the concerned manager issue is still pending. Now, let's look at the progress, how they have done. As of May 23, 38 crores ABBA card has been issued, which is 28% of our population. 26 crores health records I got linked, which is about 19%. But only 1.63 lakhs doctors have joined. That is only 6% of the doctors, nurses, paramedics, physiotherapists, etc., have joined ABDM. 94% have not joined the digital platform, which means citizens cannot access them. You have to go and stand in line in the OPD. You can't take an appointment. You cannot have a telemedicine with them. And this is a serious problem because this aspect of doctors having to join ABDM through a hospital or through a private clinic, what would be the thing? Any private clinic has got a license. Every hospital has got a license. So they have to quote that license and join. But for some reason, doctors and nurses and others are disinclined to join ABDM. You see the low percentage. And hospitals, only 18% of hospitals have joined. 82% of hospitals have not joined ABDM. So out of the 3 core sectors, citizens, leave out the citizens. The balance 2 core sectors were very poorly populated from both doctors and hospitals. This is a serious issue. And how this has to be overcome is something which the central government and the state governments had to think about. We'll talk about it a little later. So while this has got released, WHO has come out on June 6th, that's about 4 days back, saying many countries should look at India, how they can have a digital health mission, so that obviously is looking at countries which are not the developed countries, the developing countries and less developed countries. He is encouraging them to look at how India has launched this, even though our result has not been very good. The benefits of ABDM are therefore not being realized by citizens today. They're supposed to give easy access. It's happened. The doctors are supposed to give continuum of care through ABDM. It is not happening because doctors are not registered. So they expect the patients to come back to them to their clinic, come back to them to their hospitals. Most of them are staying out of this ABDM. It is supposed to minimize the replication of tests on patients. That also may not have happened. The same test gets replicated on the patient by the labs or by the scanning centers. But one issue which has happened, interestingly, is telemedicine. And I'm going to show you how it has happened. Telemedicine has picked up in the last 6 months immensely in India. It's called e-Sanjeevani. It has been developed by CDAC, Pune. Nearly 10 crore patients have been served through telemedicine, their consultations. They're able to video conferencing along with you. This is primarily done from a primary health center. So the primary healthcare assistant is sitting next to you and you say, I got a red mark here. So the doctor is able to see you through the video conferencing, or the doctor wants to know how is your blood pressure for something else. So the healthcare assistant who's sitting next to you takes the blood pressure and tells the doctor, and this is it. And then he talks to you more, and thereafter he advises you the treatment, how it has to be progressed. So this is actually picked up, especially in rural areas where people have to travel a lot of distance to see a doctor. While the primary health center, they are able to see the assistant, the doctor doesn't turn up or the doctor is absent, they are able to speak to another doctor in another center or in a nearby hospital, and they are able, this has saved time and cost by nearly 30%. So one of the benefits of ABDM has been on telemedicine. In fact, most you will see 57% of the 10 crore, that means more than nearly 6 crore have been seniors, have been women. They find it difficult to leave their home and go to a hospital which is far away and be away from home for many hours in the day. So they go to the nearby health center, and from there they are able to do video conferencing with the doctor on the other side. 57% has been women and 12% have been senior citizens. And that's how the savings have come, and they have been able to practice telemedicine with the doctor. This has happened very well. This, as I told you, this has been coordinated by the primary health center, which have been reworded as wellness center. And based on the results and based on the experience, CDAC is modifying this eSanjeevani to 2.0 so that there are some more features can be added to it. Now, I'm sorry. Now, as I told you, ABDM should only create digital records of the concerned patient, but the concerned manager software is in phase 2, is still not ready. Hopefully, it should get. Medical insurance also will get introduced through this, integrated through this. So many times, insurance claims which are forwarded to insurance companies presently don't tally with the case sheet of the patient or the actual illness of the patient. Now, there is a history to that, and it is auditable, it is traceable, and it can be looked into by agencies. Otherwise, insurance companies were paying a lot of money based on the documents which are submitted. So, what is the shift has been? Earlier, our medical treatment, our healthcare has been evidence-based planning has come now, and government has been able to make fresh policies to make sure the wellness centers, which is a basic healthcare unit, is able to participate more meaningfully with the patient, with the population, especially in rural areas. So, I told you some time back, digitizing health is like running like a marathon and not a sprint. If the government thought it is a sprint when they launched in 20, in 23, they have not reached the destination. Other countries have taken 6 to 7 years, advanced countries, developed countries. But I think we are running a marathon, and let's look at what are the challenges we are facing. The first challenge is internet availability in rural areas. Not all rural areas have. Interoperability I talked to you about, but this will get overcome only in a few years' time when new equipment which are having this interoperability feature will kick in. There's a worry about security and privacy of patient data, and this can be overcome only with people getting convinced that their health data is not getting compromised. There is a disinclination amongst doctors to come onto the platform, as well as hospitals. And this can happen only if some coercion, some persuasion takes place through the hospitals on the doctors that they have to make themselves available to a general public, to a general citizen. If a general citizen asks for an appointment, you can say you're not free and don't give an appointment. But the fact is, you have to be on the platform so that you're accessible to the citizen and he can try to contact you and try to meet you. you cannot close your door and say, I'm not joining the platform. So there is some issue of morality here of the doctor. This needs to be looked into in a little more detail by the central government and state government. We'll touch upon this in any of the Q&A aspects. And the design has to be very user-friendly. That's very clear. So when this ABDM comes, the shift is actually from episodic case, episodic care. Somebody had a heart attack, it's an episode, and everybody attends to that patient. But now, with telemedicine available, with rural health centers, wellness centers connected, people are getting advice on long-term management right before an episode occurs. So as his condition is slowly deteriorating, the doctor is able to advise him, correct his habits, give him some treatment, if required, a hospitalization. But the fact is, it is not a sudden episode which has happened. So there's a shift happening slowly from episodic care to long-term management, proactively. And the trust between the patient and doctor has slowly started increasing in rural areas, especially through telemedicine. This is the challenge which the government saw will be difficult to generate and build, but I think they have made some beginning in this area. But what they have not been able to do is doctors not coming on board, hospitals not coming on board, thereby shutting their door to ABDM, which is otherwise having citizens waiting on the other side of the door. So let us look at what is the future of ABDM. Future of ABDM is definitely like in other countries, other digital health missions, artificial intelligence is going to come. They feel, many developed countries feel the burnout and fatigue of doctors will reduce. Remote monitoring is possible through wearables and ingestibles. Evidence-based management will enhance. Robotic caregivers will come. Software as medical devices. Cost saving in a big way. And US expects a cost saving of $250 billion a year after 2-3 years. Well, it's not fully set up, US digital health mission, but they feel a lot of time and money will get saved, which will amount to $250 billion. And another aspect about digital health missions like ABDM, healthcare data will bring in automatically big data analytics into it. Healthcare data as such has got what is called 4 V's. There's a huge volume of healthcare data. The veracity is important. The velocity with which it changes, data change is also important. And there's variety as well. So all these needs to be duly protected. Privacy has to be accorded. So big data analytics has got a huge challenge when it comes to healthcare, but they feel that they'll be able to overcome, and in the future, you will be able to get not only macro data from the digital health module platform, but also be able to bring in artificial intelligence modules, which will help in doctors spending more time with the patient. They won't get fatigued out seeing too many patients. The government has taken initiative to protect the data and the privacy of a patient, and they have brought a new law, which I'm told, which I read, that it will come to the Parliament in July 23. It is called Digital Information for Healthcare Act. So DISHA, as it is the short form, it is expected that this digital info security for healthcare will get discussed in Parliament, and that will also overcome one of the challenges which ABDM is facing today. So if Disha comes, privacy and security will get addressed. Telemedicine has already made some good beginning. If doctors and hospitals can come on board, then ABDM can start moving forward. Otherwise, it is not moving forward. You're running a marathon, but your steps are very, very small. So with this, let me go to the conclusions. I've already told you 42% is by government and rest comes from out of pockets. It's a huge burden on citizens. Our public health has improved the last 10 years, but the distribution of healthcare facilities and professionals is skewed, which needs to be overcome. New technologies to render healthcare is important, has become inevitable for us to introduce this. And many countries have gone to digital health. It's a fusion of healthcare and digital technology. India has also launched the Think Big mission, ABDM, in 19. It started small in the 6 union territories. It was scaled fast to states, but cooperation from hospitals and medical fraternity has fallen short. It is hoped the ABDM, which has been accepted by 36 crore citizens, 1/4 of our population, will start becoming popular when the doctors and hospitals also come on board. There could be a reason why they're not coming on board, and I'm sure some of the doctors in the audience will share that aspect with us today. And the challenges faced by ABDM is not unexpected by many, because it's a marathon and not a sprint. And we hope we'll be able to complete ABDM in its full measure at least by 2030, in another 7 years' time, because we haven't really covered much. So let's hope that we will be able to not only set up ABDM in our country by 2030 in full measure, but also guide many other less developed countries, as also commented upon by WHO during this period between now and 2030. With this, I have concluded my presentation. Jai Hind to all of you, and thank you very much. If there are any questions, I'm prepared to take. I'm stopping my sharing of the PPT.
So thank you very much, sir. It's a wonderful presentation, really, because Health Mission is definitely in a very big movement. Basically on APA and ABDM and UHI, these are all really wonderful things. And e-Sanjeevani, that's really great. People are accepting that. And on behalf of India, it's a very wonderful project. എനിക്കൊരു സംശയം, ഇതിപ്പോ ഡെവലപ്പ് ചെയ്ത് കഴിഞ്ഞാൽ വിദേശങ്ങളെ പോലെയാണോ, വിദേശങ്ങളിലുള്ള പോലത്തെ ഒരു മെഡിക്കൽ ഹെൽപ്പാണോ കിട്ടുന്നത്, അതോ ഡിഫറെന്റ് രീതിയിലായിരിക്കും?
No, the digital health programs in many countries are not the same. There are differences there. First of all, the definition of digital health is also not agreed by many professionals, many doctors, many scientists. But by and large, it is essentially to give a longitudinal history of a patient to a doctor. That means when you go to a doctor, the doctor is able to separately see your entire medical history, what operation you had 5 years back, which hospital you got admitted 3 years back, what episode happened 1 year back, what medicines you have been having, and what has been what is the present situation, and what are the problems you are facing. So the longitudinal history is available to the doctor from the documents. Now, is it not available today? Of course it is available if you go to the same doctor and same hospital, right? Or the patient carries all his papers and goes to and shows it to the doctor. Does the doctor have time to go through all that while he is seeing a patient? We'll have to look at that. So if it is all available through the digital system, I would expect the situation will be like this. Let's say you take an appointment to see a cardiologist in some hospital. Let's say Amrita. You take an appointment and he gives you an appointment at 12 o'clock in the afternoon. It's a very reputed cardiologist. He's going to examine you, but he may not have enough time to read your longitudinal history, right? And you don't want to go to that hospital much before 12 o'clock when your appointment is. But the doctor will always have an assistant, another doctor, a PG student, somebody else. He'll say, look at this case, look at the longitudinal history, study and brief me before the patient comes, and highlight, which today is not possible unless you're going to the same hospital where all your electronic health records are kept. So when the patient meets a doctor who's better informed now, he is able to give you a very specific medical advice based on all your history, which otherwise he will have to assimilate after spending about quite a lot of time, maybe 15 minutes, 20 minutes, half an hour on your records. So there is a benefit definitely in this. There's also a benefit. The patient can easily refer his own ECG or his own blood and this thing to another friend, another doctor, another uncle who's somewhere, some other city in India through this link. Of course, you can tell him, you can always take a scan and send by WhatsApp and all that. But the UHI will be able to send through that, and you will be able to take parallel inputs, second opinion, third opinion, you will be able to get for your own comfort. So there are a lot of benefits in this. Of course, the problem is that data should not be lost, data should not be stolen, and your privacy should be maintained. So that is what is one of the challenges.
Yes, ആർക്കെങ്കിലും എന്തെങ്കിലും ഡൗട്ട്സ് ഉണ്ടോ? സുലൈമാൻ സർ അഡ്മിറ്റ് ചെയ്യും. റോയ് സർ.
Doctors, if there are any.
സർ, എനിക്ക് ഡൗട്ടല്ല. വാസ്തവത്തില് ഈ ഡിജിറ്റൽ മെഡിക്കൽ സിസ്റ്റം വളരെ നല്ലൊരു കാര്യമാണ്. ഇന്ത്യ അത് ഓപ്പറേറ്റ് ചെയ്യുന്നു, അതിന്റെ റിസൾട്ട് വരുന്നുണ്ട്. പക്ഷെ കോമൺ മാൻ ഇത് അപ്രോച്ച് ചെയ്യാൻ വളരെയേറെ ബുദ്ധിമുട്ടുകളുണ്ട്. അവന്റെ അറിവില്ലായ്മയാണ് ഒന്ന്. രണ്ടാമത്തെ കാര്യം, ഡോക്ടർ ടു ഡോക്ടർ ഈ മെസ്സേജസ് ഒരു ഡോക്ടറുടെ കയ്യിൽ നിന്നും മറ്റൊരു ഡോക്ടറിലേക്ക് വിടുന്നതിന് there is some reluctancy. കാരണം അത് മണി മാറ്റേഴ്സ് ആണ്. അപ്പൊ എന്റെ ഹോസ്പിറ്റലിൽ വരുന്ന ഒരു രോഗിയെ എന്റെ ഹോസ്പിറ്റലിൽ തന്നെയാണ് ചികിത്സിക്കേണ്ടത്. അവിടെ മണി മാറ്റേഴ്സ് മാത്രമാണ് വരുന്നത്, എസ്പെഷ്യലി ഇൻ ഇന്ത്യ. ഇപ്പോ കേരളത്തിന്റെ സ്ഥിതി, ഞാനൊരു സ്കാനിങ് റിപ്പോർട്ട് കിട്ടി, എനിക്കൊരു സെക്കൻഡ് ഒപ്പീനിയൻ വേണം, മറ്റൊരു ഡോക്ടറെ അടുത്തേക്ക് പോകുമ്പോൾ ആ ഹോസ്പിറ്റൽ പറയുന്നത് യു ഡു സ്കാനിങ് ഹിയർ. ഇപ്പൊ കൊണ്ടുവന്ന സ്കാനിങ്ങിലൊന്നും നമുക്ക് വിശ്വാസമൊന്നുമില്ല, അതുകൊണ്ട് ഇവിടെ തന്നെ ചെയ്തോളൂ. ദി മണി മാറ്റർ. അപ്പൊ അത് നമ്മൾ എന്തിനാണോ
patient is suffering.
Yeah.
So what is good for the citizens? Let us talk. It may be good for the doctor or good for hospital. Leave out that. But for the patient, he is suffering because some tests are replicated.
Yes, sir.
Very often unnecessarily.
Yes.
Right? And it is the patient is helpless. The doctor doesn't see him unless the scan is done in the scanning center opposite the gate. So definitely there may be commercial interest in making sure that the tests are replicated. But the aim of the government is to make sure citizens benefit.
Yes.
Becomes affordable. So that that is the aim. So obviously there will be opposition, and we have seen that opposition you said it, you're a doctor yourself, you said it. And that is why the low percentage of doctors willing to enroll themselves. Just now, will a law come is an issue. If legally a doctor is forced to join this for his license to be extended, if such a law comes, then there will be some pressure on the doctor. So it may not happen before 2024. Okay. So no, what I'm saying is willingness is one part of the doctor to be agreeing that anybody can take an appointment with me. You need not give an appointment, but people can ask. Okay, so this is something which is trying to build a digital health system by which accessibility is uniform. It is inclusive of all sections of society. And soon it is expected another 10, 15 years time, people will go themselves. They will not run from their village to Apollo Hospital in Chennai. They will go through this digital platform and try to get into first good advice. They may follow it and they may not require a hospitalization. Or they may get hospitalized in a hospital which is not a private hospital, which may be a public hospital. It is expected that with this, even the hospitalization rate, the number of bed occupancy will come down in many hospitals if people are made more healthy. The number one aim is to make healthcare long-term management and not episodic. You're not reacting to somebody's heart attack. You're not reacting to somebody's some stomach pain and then ultrasound and this, that. You are trying to advise him on a long-term basis to be on wellness of a high level. So that is the primary aim, and that is how many other countries in Western world have been able to bring in this digital health issue. The digital health concept is based on that. Because of the reach, coverage, speed with which medical advice, medical consultation is available to a citizen. I'm not even going to treatment. I'm not going to hospitalization. Medical advice and medical consultation is available to a patient from his comfort places, maybe from his house, maybe from his office, maybe from the primary health center, if it's in the village. So there are implementation issues, problems, which I have touched upon. Is a grandiose scheme which government has started. It's very ambitious, but I think given some years, we may be able to come to their target.
With all cooperation of the technicians, doctors, and everybody, this mission can be satisfied 100%.
Yeah,
Without
that's
the
a big if.
cooperation of...
That's a big if.
Thank you.
Thank you.
ഇന്ന് ഞാൻ ഒരു യാത്ര നടത്തിയപ്പോൾ 2 വെൽനസ് ക്ലിനിക് കണ്ടു, ഗവൺമെന്റ് സപ്പോർട്ട്. അപ്പൊ ഞാൻ ആലോചിച്ചത് എന്തിനാണ് ഈ വെൽനസ് ക്ലിനിക്? സാർ അത് പറയുമ്പോഴാണ് മനസ്സിലായത് കറക്റ്റ് വെൽനസ് ക്ലിനിക്കിലൂടെയാണ് ഈ പ്രോസസ്, ഈ സഞ്ജീവിനി അങ്ങനെയുള്ള പ്രോസസ്സുകൾ നടക്കുന്നത്.
E-Sanjeevani has really picked up in rural areas because people want to meet a doctor and talk to him and tell him, and he gives some advice. Maybe half the cases it's out of anxiety, they are wanting to talk to the doctor, but they have made it approachable. They are able to do it from the comfort of primary health center with a doctor who is in the town nearby or a panchayat or some bigger place. That the wellness center ensures it happens.
ഞാൻ ആലോചിക്കുക എന്താണ് ഈ വെൽനസ് ഗവൺമെന്റിന്റെ സിസ്റ്റത്തിൽ മോഡേൺ മെഡിസിനോ അല്ലെങ്കിൽ ഓൾട്ടർനേറ്റീവ് മെഡിസിനോ?
It is essentially on medical advice for good health habits
preventive
and good practices. Wellness center will say every day you please walk for half an hour. He will say that. You do some exercise for 20, 30 minutes. He will tell you. He said, don't drink too much or avoid very fatty food. All these things the wellness center will say, many of which we know and we tell our children. So there's a wellness center in the house itself, which happens, even though there may not be a doctor, based on our experience.
Roy sir.
സാറേ ഈ അലോപ്പതിക് മെഡിസിൻസിന് മാത്രമല്ലേ ഇത് പറ്റുള്ളൂ ABDM? മറ്റേ ആയുർവേദം മറ്റു ഡിസിപ്ലിനുകളിലൊക്കെ പ്രാക്ടീസ് ചെയ്യാൻ പറ്റത്തില്ലല്ലോ.
Can I just increase my volume? I'm not able to.
സാറേ ഈ അലോപ്പതിക് മെഡിസിൻസ് ഉണ്ടല്ലോ, ഇംഗ്ലീഷ് മെഡിസിൻസിന് മാത്രമല്ലേ ഇത് പ്രാക്ടിക്കൽ ആവുള്ളൂ?
Correct.
മറ്റേതിനൊന്നും ആവത്തില്ലല്ലോ.
Yeah.
Okay, sir.
So it is possible. As ABDM, it includes Ayurveda. It includes other forms of medicine, alternative medicine also, right? They are also part of this program.
Sir, ഈ പ്രസന്റ് സിനറിയോയിൽ ഇത് മാത്രമല്ലേ ഉള്ളൂ? ഇപ്പോഴത്തെ ഈ ഗവൺമെന്റിന്റെ ഇതില് ABDM എല്ലാം ഉണ്ട്.
No, it includes the Ayush Ministry is also participating in this.
Okay.
Where other forms of medicine are also included in this. You want to consult Ayurvedic doctor, you can take your appointment through this and discuss with him.
Okay. ഇപ്പൊ സാധാരണ ഇപ്പൊ ചില ഹോസ്പിറ്റലുകളിലൊക്കെ കാരിത്താസിലൊക്കെ എന്ന് പറഞ്ഞു കഴിഞ്ഞാല് എല്ലാം ഇതുപോലെ ഫയൽ മാറി എല്ലാം കംപ്ലീറ്റ് കമ്പ്യൂട്ടറൈസ് ചെയ്തപ്പോൾ ഒത്തിരി സൗകര്യങ്ങൾ പബ്ലിക്കിന് വരുന്നുണ്ട്. പക്ഷെ സാധാരണക്കാരായ ആൾക്കാർക്ക് അത് അത്രമാത്രം അഡോപ്റ്റ് ചെയ്യാൻ പറ്റുന്നില്ല. പക്ഷെ ഇത് ഗവൺമെന്റ് ഹോസ്പിറ്റലുകളിലൊക്കെ ഇത് ഇംപ്ലിമെന്റ് ചെയ്യാൻ.
No, I have a slight difference of opinion here. Computerization is happening in OPD.
Okay.
They'll give you a printed from the computer, and print will come for your OPD chit. Right? But all those workflows which are there are restricted to that hospital only. Okay. All the data which is there are not interoperable.
Okay, sir.
So you're going to, you are in Kottayam, let us say, and you're going to Kannur, and there you want to go and consult a doctor, but all your data is in Kottayam hospital. You will not be able to access it.
Okay, sir.
But if you have a UHI, it will be able to fetch the data and you give the consent.
Okay.
Please confirm you can give to doctor so and so. You say yes, it will come. The link will come to the doctor.
Okay, sir.
Provided he is registered on UHI.
Okay.
Anything else? Anybody else?
Sir, మీరు പറയുന്നു.
എനിക്ക് വലിയ പറയാനൊന്നും ഇല്ല. പക്ഷേ യൂട്ടോപ്യൻ ഐഡിയ ഇന്ത്യ പോലെ രാജ്യത്തിൽ ഇത് കൊണ്ടുവരാൻ. കാരണം ചിലപ്പോൾ ഈ സഹകരണം ഒരു സ്ഥലത്തും കിട്ടത്തില്ല. ഇപ്പൊ കണ്ടില്ലേ, ഗവൺമെന്റ്സ് തന്നെ അങ്ങോട്ട് കൊണ്ട് സഹകരിക്കുന്നില്ല. അതുകൊണ്ട് ആ കുലഹന്നം പറഞ്ഞു അല്ലേ, ചില മെഡിക്കൽ ഫ്രറ്റേണിറ്റിയുള്ള ആൾക്കാർ സഹകരിക്കുന്നു. 1.6% ആൾക്കാർ മാത്രമേ വന്നു. എവരിബഡി ഉണ്ട്. ഇപ്പം അത് അവരെ ഫോഴ്സ് ചെയ്യിക്കണമെങ്കിൽ ലാ കൊണ്ടുവരേണ്ടി വരും. ലാ കൊണ്ടുവരുമ്പോൾ അതിന് ബഹളം ഉണ്ടാക്കും. കാര്യങ്ങൾ നടക്കത്തില്ല. ഇതാണ് അല്ല നടക്കില്ല, ഇറ്റ് വിൽ ടേക്ക് ടൈം. ബട്ട് വിൽ പവർ കൊണ്ട് നടക്കും. ഫോർ എക്സാമ്പിൾ, ക്ലാസിക് എക്സാമ്പിൾ ഈസ് കൊറോണ വന്നപ്പോൾ വാക്സിനേഷൻ തുടങ്ങിയപ്പോൾ എന്ത് ബഹളമായിരുന്നു. നമ്മൾ വാക്സിൻ ഇവിടെ പ്രൊഡ്യൂസ് ചെയ്യാൻ പാടില്ല, വി ഷുഡ് ഇമ്പോർട്ട് ദ കൊറോണ എന്ന്. സംബഡി ടുക്ക് എ വെരി ഫേം ഡിസിഷൻ, ഇവിടെ തന്നെ പ്രൊഡ്യൂസ് ചെയ്യും, ഇവിടെ ചെയ്യും. ആൻഡ് വി ക്രിയേറ്റഡ് ഹിസ്റ്ററി. നമുക്ക് മാത്രമല്ല, വി കുഡ് ഇവൻ എക്സ്പോർട്ട് ടു ദി നീഡി കൺട്രീസ്. അതുകൊണ്ട് ഒരു കുറെ അത്ര എളുപ്പമുള്ള കാര്യമല്ല, പക്ഷേ നോട്ട് ഇമ്പോസിബിൾ ക്ലാസ്, ഇറ്റ്സ് പോസിബിൾ ക്ലാസ്. പിന്നെ വൺസ് ഇറ്റ് ഈസ് എസ്റ്റാബ്ലിഷ്, ഇറസ്പെക്റ്റീവ് ഓഫ് ദി എനി മെഡിസിൻ, യുനാനി ആയിക്കോട്ടെ, സിദ്ധി ആയിക്കോട്ടെ, ആയുർവേദ എല്ലാം ലിങ്ക്ഡ് ആയിപ്പോവും. കുറെ കഴിഞ്ഞാകുമ്പോൾ ഇറ്റ് ലുക്ക് പ്രാക്ടീസ് ആയി. പക്ഷേ മിനിമം അക്കോർഡിംഗ് ടു മീ മിനിമം അനദർ 25 years എങ്കിലും ആവും ഇതൊക്കെ ഒന്ന് എസ്റ്റാബ്ലിഷ് ചെയ്ത് കിട്ടാനുള്ള അഭിപ്രായക്കാരാണ് ഞാൻ.
Yeah. So the major issue which I told you is, even though citizens were paying out of their pocket, 62% of the expenditure was borne by citizens 4-5 years back. Now it has slowly come down to 47%. But almost half the money for your treatment is being paid by poor citizens because government doesn't have enough money and government hospitals are not able to treat so many people. So they go to private and private will charge you. So there's a problem with this. So we need to look at this issue, is it how it can be made universal. And like Hari said, it will take some time. So I told you it's a long marathon which you have to run.
I have a small suggestion. One suggestion is medical insurance in the premium so that it is affordable to the lower income group people. High premium so that more people take the insurance policies. So if 10% and a couple of years 20% insurance.
So I think you are saying something very correctly, because soon medical insurance you can take for a person only if he's in ABDM. That will come after some time. All insurance will get linked to ABDM. And no doctor can give you a certificate for insurance claim unless he's a part of ABDM.
Yes.
Otherwise, it will be like Mugundan and Associates, that movie, where he has been getting medical certificates issued and taking money out of insurance company. So there are many ways you can nudge people to become a part of this program. It's a national program. It has got a lot of opposition. I can see it. I don't know, opposition may not be a good word, but they're not inclined to join this, because many people feel that a lot of income of private hospitals will reduce if this comes. And a lot of other ecosystem which thrives on a private hospital around that. It could be an ambulance, it could be hotels, it could be some other medical shops. All of them survive because the hospital is located in one particular place and patients are coming there in big numbers. But if they're all coming through digital platform, the number of people visiting the hospital also will be less. So this will take some time, but the digital mission is slowly it is moving, and I hope we are able to see some
changes,
success in this in the next 5-6 years.
ഈ ജനറൽ പബ്ലിക്കിനെ കൂടി ബോധവൽക്കരിച്ചാൽ മാത്രമേ ഇതിനൊരു താല്പര്യം വരുള്ളൂ. ഇതിപ്പോ ഞാൻ തന്നെ വളരെ കുറച്ച് ഇപ്പൊ സാറിന്റെ ക്ലാസ് കേട്ടപ്പോഴാണ് ഇതിനെക്കുറിച്ച് എനിക്ക് ഒരു ഐഡിയ ഉണ്ടായത് തന്നെ, ഈ ABDM-നെ കുറിച്ച്. അത് സാധാരണ ഈ പൊളിറ്റീഷ്യൻസിനും ഒന്നും ഇതൊന്നും അതിനെക്കുറിച്ച്.
I'm happy that I gave this talk. There are 10 people here, and I don't think anyone has heard ABDM before.
Okay.
Yes.
So maybe Dr. Ulhanan has come across that. But otherwise, the rest of the people are not. No, the government is also not talking much about it.
Yes.
So as I told you, the phase 2 is not complete, where some of the interlinking modules, digital modules, are still not developed. They had some problem, so they have put out a technical paper on it for consultation, and it's hoped that this will get resolved. But the leadership of NHA has been very good. You remember the man called Dr. Sharma, who was heading COVID. He was asked to do this. Of course, he's retired now, and somebody else has taken over. But the fact is, it is within our capability to develop this digital platform.
Yes.
Only thing you have to make sure all medical equipment conform to that IEEE standard. Otherwise, you can't exchange data from one equipment to the server, because the server in the private hospital has to be compatible to UHI protocol. So the medical equipment which is speaking to that should be compatible. I don't know how many hospitals have, let's take Apollo Hospital, whether all the MRI is done in the hospital is centrally stored. All the ECGs are centrally stored. All the ultrasound is centrally stored with patient's name. So whenever that particular patient comes back, he is able to see his old record. I don't know how strong is how disciplined is this field in a private hospital. I would presume it is not so. It is not so. It may be stored, but retrieval may not be that easy. Sabu, anybody else? Anything else?
Okay, nothing else, sir. Thank you. Thank you very much.
Yes, sir.
Thank you very much. Thanks a lot. Thank you. I
Thank
know
you
it has
very
been
much.
a very futuristic one, but I thought I should tell you about digital health, which is not moving the horizon.
Yeah, yeah. Really
Bye-bye.
wonderful, sir. Thank you. Thank
Thank
you.
you.
Thank you very much.
Thank you. I'll leave the meeting now.
Okay. Have a nice day and thank you.
Thank you.
Good night.
Thank you, sir. New information in wide range. Thank you very much. Thank you.
നമ്മള് കേട്ടിട്ടില്ലാത്ത അത്ര മനോഹരമായിട്ടുള്ള കാര്യങ്ങളാണ് പറയുക.